has. So next we move on to the next session on traumatic optic neuropathy. I invite Dr. Anitha Prabhakaran. She's a pediatric ophthalmologist from Precise Hospital, Trivandrum. Over to you, Dr. Anitha.
A very good afternoon to one and all, and thanking for the opportunity. Let us deal with the next sector of optic neuropathy, which is related to trauma. Whenever I hear this topic, I get vivid thoughts, vivid memories of a teenage boy coming to our OPD when I was doing my second year PG way back in 1998 in Madurai Medical College. He had presented with diminution of vision in one eye, and he had features of optic atrophy. On detailed history taking, he denied any history of trauma to the eye, but on repeated questioning, he remembered that he had sustained some trauma to the forehead, just above at the supraorbital region. He had some trauma to the forehead, and both he and we PGs were quite upset that we had no treatment to offer as well. It was Hippocrates who first described the term traumatic optic neuropathy in closed head trauma patients, and by definition it is any insult to the optic nerve secondary to trauma. Either it could be a direct trauma to the causing damage to the optic nerve, or it could be an indirect trauma where the deformative stress will cause is concentrated on the optic canal area, and depending on the site of injury also it is classified, and the most commonest lesion is at the intracanalicular part. So as we can see here, when there is a direct traumatic optic neuropathy, there could be a projectile or some kind of a trauma which causes significant anatomical disruption of the optic nerve, leading on to optic nerve avulsion, transection, optic nerve hematoma, and the like. And here the patient presents with severe visual loss and the poor almost NLP, and the visual prognosis is also very poor. Whereas in indirect traumatic optic neuropathy, it's a mechanical impact. The injury is actually from a distant site, and there is no overt damage to the surrounding structures. But because of the dural sheath is tightly adherent to the periosteum at the intracanalicular segment, that is the most susceptible, followed by the intracranial portion where there's a close proximity to the falciform dural fold. So why does this happen? There is actually a primary and a secondary injury going on. So that's a two-stage model theory, where the first, what happens is a shearing of the ganglion cells and interruption of the blood vessels, and that causes ischemia and optic nerve swelling, which leads on to a compartment syndrome, and this pressure effect will cause an apoptosis which will continue as a vicious cycle. So that is where the role of decompression comes in. And the biomechanics was tried to be explained with a computational head model, which showed that this 45-degree injury, trivial injury, is to the frontal area, to the supraorbital area, is more likely to cause a traumatic optic neuropathy, which explains the boy which we had seen. So clinically, we need to get a detailed history of the trauma and to look at features of optic neuropathy and any other associated injury to the orbit and the adnexa. So usually it could be unilateral or bilateral. There could be RAPD is the pathognomonic finding of traumatic optic neuropathy. If there's no RAPD, it's not a traumatic optic neuropathy, or it is a bilateral optic TON. And the vision loss can be variable. It could be more rapid than that seen in the toxic and compressive type. Of course, color vision and visual fields will be defective as in optic nerve involvement. If the injury is anterior to the point of entry of central retinal vessels, you can see some hemorrhages with optic disc swelling, but if it is posterior, the fundus will be normal. It takes about 6 weeks for optic atrophy to set in. How would you manage? First, we talk about investigations as usual, but here we know that to demonstrate optic nerve sheath hematoma, optic canal fracture with the bone impinging on the optic nerve, we need to have some neuroimaging. And the argument is that the neuroimaging should be done at the earliest, so that if there is any bone fragment, it has to be surgically removed to. But the counter argument is that irrespective of the treatment modality, there is no, the visual recovery, very poor prognostic factor for visual recovery. Hence, right from the investigation till the management, I will be continuing to speak about, continuing to remember Shakespeare's quote of to be or not to be, because neuroimaging is again a questionable. The clinical usefulness of neuroimaging in traumatic optic neuropathy is not been, it remains debatable, as there is no consistent correlation between the presence of a fracture or location of a fracture with the severity of visual loss or a visual recovery prognosis as well. So whether it should be done for all cases cases or only those which are progressing or those which needs intervention is still questionable, and which modality. CT is the best modality to delineate the optic canal lesions, and whenever you do an MRI, make sure first you're doing an X-ray to rule out a metal intraocular foreign body. And coming to the management, as we said, in direct traumatic optic neuropathy, because it's a very severe irreversible visual loss and no intervention is of any proven benefit, whereas in indirect traumatic optic neuropathy as well, there are no confirmed protocols for prevention, mitigation or treatment. The main stay of treatment includes steroids, surgical decompression, a combination of these two, or observation. But of course, we need to remember to rule out a possibility of retrobulbar hemorrhage and to watch for development of optic nerve sheath hematoma, where we'll have to relieve the pressure by head and elevation, tapped IMOX, and if at all needed, a lateral canthotomy as well. So there were studies on acute spinal cord injury where they gave steroids within the first 8 hours, and they found significant improvement in the neurological functions. And that was the basis of giving steroids in optic neuropathy as well. And the steroids which are given are very high dosages, which are even mega dosages. But no significant difference was found in the final visual outcome, even with higher dose of steroids or with an earlier initiation of treatment. At the same time, there were serious systemic complications and more mortality in patients who were treated with steroids, especially in people with predisposing factors. One more thing is, instead of the benefit, there was some adverse effects was found, and which exacerbated the retinal ganglion cell loss as well. And regarding the surgical options, we have the intra or the extracranial or endoscopic optic nerve decompression. Again, the timing is controversial, whether you should do it immediately to salvage the ganglion cells, but there is conflicting evidence that there is no difference between whether you do it immediately or not. There is no impact on visual recovery. And on the effectiveness of surgical decompression as well, there are no RCTs. So and here also we have to consider the very potentially serious complications like CSF leak, meningitis and accidental dural exposure. So we want to draw your attention to this largest prospective multicentral trial of traumatic optic neuropathy which was ever published, and here it's very clearly seen that it is the observational group which has the maximum visual recovery when compared to the interventional groups. So we can only predict the prognosis. That is the most important predictive value is the visual acuity at presentation, and any lack of visual recovery after 48 hours, even after steroids, is a poor prognosis. Other poor prognostic factors are loss of consciousness, age over 40 years, high grade of RAPD and absent visual evoked response, and lower the flash VEP amplitude, lower the latency, worse the prognosis, and presence of blood within the post-ethmoidal cells and an OCTA showing poor inner retinal capillary density are all poor prognostic factors. There are some studies still going on. Some results have been published, which is known as a traumatic optic neuropathy treatment trial, where they have tried erythropoietin and levodopa plus carbidopa along with steroids and compared it with observation. It started in February 2011. Still some part it is going on, but as much as the results are published, it is promising because there is some improvement in color vision and RAPD, but the final visual recovery is still the same. So the practical considerations, there is a narrow window for initiating the treatment, and because of other life-threatening injuries, there is an unavoidable delay in diagnosing the traumatic optic neuropathy. With the relatively high rate of spontaneous visual recovery and no convincing evidence that steroids or surgery provides any additional benefits, to subject a patient to these potentially complicating interventions has to be considered with caution, and any decision taken as per the best interest of the patient. Thank you very much.
Thank you, Dr. Anitha, for the wonderful talk. So basically, to summarize, always and always take a detailed history. That is the most important, I think, what we have seen in all these sessions. Okay, the history is the important. At least 80% of diagnosis can be made with your history. Look at the pupil. Examine the pupil properly. Okay, so a sluggish pupil, a grade 1 RAPD should not be missed out. And look at the fundus, I think, very carefully. A disc edema, in spite if there is no disc edema, because by the time the pallor comes, the time is vision. So the later you're going to refer the patient or later you're going to diagnose, you have lost that much amount of vision. So I think you have to have a careful examination of the patient as such. And you don't have a visual field, at least do a confrontation for the patient. Okay, so visual field is not mandatory. VEP is not mandatory to diagnose this. You shouldn't be missing out anything. That is the basic criteria. And never err. Like you are thinking that whether to do an MRI or not. I think today's world, medico-legal issues are so common. Okay, you need to diagnose the patient as and when you find it and properly. Okay, so documentation is also very, very important, especially in cases of this traumatic optic neuropathy. Though maybe the treatments are not going to be very favorable, but at least you can document that you have done this and that, and maybe the vision has not improved in spite of doing that. That is what I would like to add. Any questions? I think you can ask.
Legal aspects apart, I would like to just highlight the case of actually a boy in the 20s who had a very bad RTA with the, I think he had a tracheostomy and everything. With Dr. Naina had seen the patient, and he was he had only few meters of vision after 1 month after trauma. And of course, steroids in an older patient with comorbidities, we have to take a lot of precautions in starting steroids. But we gave the benefit of doubt and started him on steroids because his vision was very low, and he was recovering from a sixth nerve palsy also, and he recovered to, I think, 6/9. Vision was surprising. So neurological problems after a trauma is very unpredictable. So sometimes we have to decide by a case by case. We have to decide whether, is the next session starting? Okay, I think.